Hi, my name is Tonya Taylor, and I'm faculty in the Department of Medicine and Division of Infectious Disease at SUNY Downstate Health Sciences University. I am also one of the co-directors of the BRIDGE program, which stands for the Brooklyn Initiative to Develop Geriatric Education, also at SUNY Downstate Health Sciences University. Today it is my pleasure to present a lecture on cultural humility, and it will be in two parts. And the first part is called The Inner Work. First, we would like to acknowledge our generous funding from HRSA and the U.S. Department of Health and Human Services. I want to remind you that the contents of today's presentation are mine and mine only, and that they do not reflect the official views nor endorsement of HRSA, HHS, or the U.S. government. I have no conflicts of interest. Before we get started, I would like to just remind you about our framework for developing and promoting age-friendly healthcare systems here in Brooklyn. This revolves around the 4M's framework. The first M is what matters, which is knowing and aligning what is most important to your patients with what is included in their care plan. No issue is too small, especially if it impacts quality of life. The second M includes medication. As we get older, we start to accumulate more and more medicines called polypharmacy, and it is therefore imperative that at every visit we do a medication reconciliation to make sure that the medicines are being taken properly, etc. And if not, there is the risk of poor medication adherence impacting what matters, impacting mobility, impacting cognitive function, impacting mental health. The third M is mentation, which is a word that encompasses both mental health and cognitive function. So here our goal is to prevent, identify, treat, and manage what we call the 3 Ds of geriatrics: dementia, depression, and delirium across all settings of care. And our final M is mobility. And here our goal is to ensure that all older adults get to remain independent and autonomous. Sometimes this might mean needing to get assistive devices, but the bottom line is, as long as we can help older adults to remain independent, to be able to do and stay in their home, such as aging in place, this is going to improve their overall quality of life. The learning objectives for today's lecture include, and again, there are 2 parts. So in part 1, we are going to define cultural humility and its sister, cultural competence, and their impact on clinical encounters. We are going to discuss strategies of learning and discuss in particular 3 enhancement tools that can be used to hone your cultural humility. In part 2, I'll just tell you now, we are going to discuss implicit bias and affinity bias and as barriers for cultural humility. And we are going to review strategies to move from awareness to action in honing our cultural humility. So first, I like to always start off with activities. And throughout my lecture, there are going to be a number of activities. In order for you to really, really get everything out of this lecture, I really hope that you will stop and do these activities, because it will absolutely impact your ability to get everything you need out of this particular lecture. So what I would like for you to briefly do is to maybe take one of these unfinished sentences, and I want you to jot down, why is this topic important to medicine? Or if you want to jot down what you already know about cultural humility and do your own pre and post tests in terms of what you know, and hopefully at the end of this encounter, you will have other things that you can add on in terms of your knowledge and expertise. And the third question is, as a future provider, what do I need to know more about this topic? I hope that you will take a moment to complete these unfinished sentences. Pause if you need to. Now, let's get into definitions. Cultural humility. Cultural humility has been defined as a lifelong process of self-reflection and self-critique. It's basically our ability to hold up our mirror and look at ourselves and to be able to try to figure out what are my blind spots? What do I need to know and understand in order to be more culturally humble? It is holding up that mirror in terms of identifying our own biases, as well as strategies to develop and maintain mutual respect and partnerships based on mutual respect. I love these two quotes. One is by C.S. Lewis: "Humility is not thinking less of yourself, it is thinking of yourself less." And then Heinrich Friedrich Emil: "There is no respect for others without humility in oneself." Now, the sister to cultural humility is cultural competence. Many, many years ago in medical education and just in terms of this type of training, the focus was mostly on cultural competence. However, about 15 years ago, there was a sea change in terms of thinking about cultural humility versus cultural competence. But I really want you to understand what cultural competence is in comparison to cultural humility. So cultural humility, again, is about self-reflection and self-critique, whereas cultural competence is, I like to think of it, is the work that is done within systems or in institutions. So it's an ongoing process by which individuals and systems, like our hospital system, respond respectfully and effectively to people of all cultures, languages, classes, race, sex, ethnicity, etc., in a manner that recognizes and affirms and values the worth of those individuals, families, and community. The difference here is that within systems, there's also the need to have safeguards to make sure that people working within those systems adhere to these principles. So one is a very individual process, and cultural competence is really about the work environment that we live in and the people in our institutions to make sure that these safeguards are in place. Why is cultural humility and competence important? Well, it might not seem obvious, but let's just talk about it. It leads to improved teaching and learning, diagnostic accuracy, patient and clinician satisfaction, teamwork and collaboration, and overall improved morale. What it reduces are complaints, grievances, litigation, and lost revenue. So cultural competence and cultural humility have a huge role in making sure that we are effective in doing the work that we are doing and providing optimal care to our older adults. A little bit more about definitions. So, since we're talking about cultural humility, I just want to back up and just maybe talk a little bit about what is culture. I'm a medical linguistic anthropologist, and culture is the particular disciplinary lens that anthropologists look at human beings, the way that we start our investigation. So this is a classic definition by Clyde Cuckone: an individual's quote-unquote patterned ways of thinking, feeling, and reacting to the world outside that are learned and shared by members of a group. Let me just emphasize this. This is basically our beliefs, our values, how we cognize the world, how we think about it, our worldview, and how we respond to it that is shared by a group of individuals. And this group of individuals or community is often linked to a shared history, a shared social legacy. And these are often the groups that we identify with as being a member of. Another thing that I'd like to just quickly define is cultural diversity. Again, cultural, to just try to de-link and make sure that we're all on the same page as we explore cultural humility. Cultural diversity, and I love this quote, is the combination of ways in which each of us is, like all others, we're all Homo sapiens sapiens, we're all the same species, like some others, and this is where I like to think of culture sitting, and the fact that some of us share particular history and cultural beliefs. But yet, I want to make sure that everyone understands that culture is not monolithic, that it is that we are also individuals and unique, and within cultural communities, there's enormous variation.